Good afternoon. My name is Caleb Alexander. I'm a founding co-director of the Johns Hopkins Center for Drug Safety and Effectiveness and a professor and practicing internist at the Johns Hopkins Bloomberg School of Public Health. I've also served as a paid expert for plaintiffs in federal and state opioid litigation. I'm delighted to welcome you to this installment of the Johns Hopkins Congressional Briefing Series, where Johns Hopkins experts provide a briefing on a topic of interest to policymakers and engage in real-time Q&A. In today's briefing, our panel will discuss innovative programmatic and treatment efforts to combat the opioid epidemic. As I know that many of you know all too well, millions of Americans have been deeply, deeply affected by this crisis. However, as we'll hear today, we are truly at a unique moment in time in our efforts to prevent further harms. There's remarkable evidence out there, and an evidence base that's rapidly growing all of the time, and also very strong consensus regarding many of the most important steps that together we can take. If there's one thing that's true when it comes to this multifaceted and highly dynamic crisis, it's that all of us are smarter than any of us. And with that said, I'm delighted to welcome four of my Johns Hopkins colleagues. Dr. Michael Fingerhood is a professor at the Johns Hopkins School of Medicine and director of the Division of Addiction Medicine. Dr. Fingerhood's expertise is in the area of addiction medicine and internal medicine. And in today's briefing, we'll hear from him regarding the treatment of opioid use disorders or opioid addiction. Dr. Tamar Rodney is an assistant professor at the Johns Hopkins School of Nursing. Her research focuses on veterans experiencing post-traumatic stress disorder or PTSD, a key group that's at risk for opioid use disorder. Dr. Rodney will discuss how emergency departments work with patients experiencing opioid addiction. Dr. Brendan Saloner is a Bloomberg Associate Professor of Addiction and Overdose at Johns Hopkins Bloomberg School of Public Health. His research focuses on access and quality of care for people with substance use disorders. And today he'll be discussing quality of care for those that have opioid addiction. And finally, Dr. Susan Sherman, who's a Bloomberg professor in the Department of Health, Behavior, and Society at the Johns Hopkins Bloomberg School of Public Health. Dr. Sherman's research focuses on improving the health of marginalized populations, particularly that of people who use drugs and sex workers. She'll be discussing harm reduction as a key component of treatment for opioid use disorder. Before I turn to our panelists for their remarks, I want to remind you that we will be providing answers to your questions. Some of you have already submitted questions, and to those of you, I thank you. But for those of you that haven't, we'll be providing an email address that you can submit questions to. So please feel free to engage with us and submit your questions. And next, I'll turn to each of our panelists for a brief overview of key topics. So first, maybe we could start with you, Dr. Fingerhood. Could you please discuss some of the current strategies for treatment of opioid use disorders?
Thanks, Caleb. So I want to first start off with the emphasis that treatment is effective and saves lives, and that means medications. But we really have to do work to improve access and convenience at how we provide treatment. As a very key first step, just a few weeks ago, Congress passed the Mainstreaming Addiction Treatment Act. And importantly, that meant that we can now use buprenorphine as a medication for opioid use disorder without the hindrance of what was called the X waiver. And I think it's going to take away excuses for not treating in most settings. But we already have a webinar coming up next week in which we try to reach out to people interested in treating opioid use disorder who hadn't had an X waiver. And we already have over 100 people signed up. So I think we have opportunity and related to, again, the Mainstreaming Addiction Treatment Act. We need to initiate treatment at many touch points as possible. And the medications are both important, both methadone and buprenorphine. And at times, with the advent of fentanyl in the last few years, many more patients are seeking methadone treatment. And I'm going to come up with 3 things that I think that we need to do still as I tell you about things we have done. And one of them is we really need to create new ways to use methadone in primary care. There is a new clinical trial looking for recruitment as we look at more creative ways that other countries have found a way to do. Now, in terms of buprenorphine, we've worked really hard to get hospitalized patients onto buprenorphine. You're going to hear from Tamar, Rodney more about emergency department efforts. And then we've also thought of novel ways of initiating buprenorphine. I'm at a church on Monday morning where we're reaching people who had never been in treatment before. We find people in their 60s with 30 to 40 years use of illicit opioids, and they haven't sought treatment. They're not necessarily going to go to an office or to a hospital, but out of a community church, they're interested in getting help. We're also working on new models of EMS initiation of buprenorphine. We just are starting initial meetings. It's been piloted in Camden, New Jersey, and I think there's going to be interest throughout the United States, as we realize that only about 10% of individuals who have an opioid overdose or in which EMS is activated, only 10% of people are actually transported to the hospital. And we need to do a better effort of getting those other 90%. There's a crucial 1 hour, for instance, where right after someone has had an overdose and that's been reversed with naloxone, that it's much more easy to initiate buprenorphine in that setting. So we're going to definitely have efforts on that part. Now, in terms of primary care, every primary care setting should be initiating treatment and integrating treatment with buprenorphine. I've led a primary care practice for over 20 years now, and we treat over 650 individuals with buprenorphine integrated primary care. And we were able to show that by doing it in this fashion, we actually had cost savings for a Medicaid population. It means that people get better care, it destigmatizes care, and it makes treatment just like any other treatment, for instance, for high blood pressure or diabetes. Also in the outpatient setting, an important thing we've incorporated in the past 2 years, really since COVID, was the ability to use telemedicine to do follow visits for people who are in treatment. And we've done that in multiple settings, including the clinic setting. And it really is important for us to be able to continue to do telemedicine for people with opioid use disorder, and including initiating buprenorphine and also follow-up visits as well, including, unfortunately, some of our patients do not have the ability to do video. We should continue to have the ability to have audio-only visits. As we've learned over the last 4 or 5 years, peers are really an important essential aspect for effective treatment. We have peers in many settings, emergency department, inpatient, outpatient. We hope to have them with EMS as well. Peers give hope, right? So peers are people who have had recovery. Some of them are on medication, and all of a sudden they impact stigma in whatever setting they work. As individuals realize these people have had recovery, I should have more hope for my patients I'm trying to treat. Over the last couple of years, we've vigorously worked at having hospital-based addiction medicine consult services where we see patients in the hospital. We've shown that by impacting, it's often starting methadone or buprenorphine, we prevent patients from leaving the hospital against medical advice. We prevent readmission. We increase satisfaction both of patients and of staff, and help patients. It also destigmatizes patients as well. In the past year, we've also piloted a clinical trial where we've used injectable buprenorphine, which lasts 30 days in hospitalized patients. We're part of a 6-center trial in the United States of initiating injectable buprenorphine for hospitalized patients. We've had a lot of increase in people with really terrible deep tissue infections in the hospital related to xylazine, and we're working on teams' approach to help these patients as well. Finally, related to inpatient, we now have an ability finally to dispense methadone at hospital discharge for up to 3 days. This has been true since November, through approval through the DEA and SAMHSA. And this is a huge plus, as patients don't have to wait in the hospital, as their methadone program may not be open for another 2 days if it's the weekends. One more wish is that we need to, well, two more wishes. We need better linkages for patients from the hospital to go to skilled nursing facilities. Unfortunately, skilled nursing facilities continue to refuse patients because they need medication for opioid use disorder. There was a paper published in the Annals of Internal Medicine, the current issue, calling out that this is clearly discrimination. And finally, the last piece we need to do, and we're working on this, is reaching out to incarcerated individuals. We need to do a better job at treating incarcerated individuals. We now have, I have faculty in my division that provide treatment in incarcerated individuals. The highest risk for overdose, which someone else may mention, is at release from incarceration, and that just shouldn't be. We should be initiating treatment while individuals are incarcerated, and that should be in all types of incarcerated settings. Thank you.
Thank you. That was a treasure trove of recommendations and interesting areas where there's important innovation taking place. So I look forward to coming back to some of those topics as we take questions from participants as well. Let me turn to you, Dr. Rodney, and ask, how are emergency departments working to aid individuals that are experiencing opioid use disorder?
Thank you, Caleb. And I wanted to start off by saying the emergency department, although we're there for emergency, it offers sometimes the only entry point for individuals who have opioid use disorder needs. And it's a crucial opportunity that all providers within the emergency room should take advantage of. Another point is that it also presents an intervenable point where we get to incorporate multiple different treatment options for those individuals. And third, that a specific population who only have access to healthcare of any kind is often underserved populations. But at this point, we not only get to see the patients, but also their family members. So when we think about strategies for individuals with opioid use disorders, we would also include their families, and the emergency department allows us to do that. And so some of the specific models that have been used in the emergency room department is SBIRT is a very popular way, previously used for alcohol use disorder, but certainly has been extended for all substances. And SBIRT really stands for screening and brief intervention referral. And if we start at the top as a strategic way that emergency departments go, is trying to screen very, very quickly, primarily to assess the severity of the substances that individual might come in, but also to make recommendations based on the appropriate level of treatment. And this approach for identifying which treatment can rely on the individual's screening tools that they use, or on the individual's self-identification of what they have taken. And also a great opportunity to use multiple different tools that are available to us, including COWS and COM, all related to opioid use disorder. And then we look at what can we do in such a limited space and time for an area where you really need to move them on to more specialized care. But it's also an opportunity to initiate some sort of brief intervention, focusing on the individual's insight and their awareness regarding their substance use and their motivation towards accepting treatment and ultimately behavior change. So emergency departments have the responsibility to either state what treatments are available, or offering treatment options because that individual might not know. And so, as Dr. Fingerhood mentioned, buprenorphine in many cases is the most feasible one to administer in the ED setting. But other ways we can extend this in the ED is to give a buprenorphine prescription to that individual as a bridge before they get to that longer term intake appointment, and then have a champion within the ED who has knowledge of opioid use disorders and have reliable connections that we connect these individuals to in the outpatient treatment area. So when they leave, they have something substantial to go on. The ED or different ED departments have gone to be very innovative in the way they present information. sometimes language barrier or cognitive issues or what they encounter. And so I found one study that went as far as giving pictures and verbal instructions on how an individual might use naloxone or how their family might use naloxone at home for administration, offering instructions in both English and Spanish if available in other languages, and initiating this talk about motivational interviewing to plant a seed about where behavior change could occur. And then the last point is referral to treatment. So identifying the individuals who need more extensive treatment and access to specialty care. These should include an approach that is patient-centered, removing as many barriers as possible, and having a very strong structure within the healthcare system to support that individual, which really means really strong community partners who are involved in this. And some of the feasible things that they can do are possibly including syringe services or providing fentanyl strips or safe injection sites, or more recently, utilizing peer recovery programming. Multiple EDs have used peer navigators or recovery coaches in the emergency department. And while we don't have much published data on it, they have been incredibly useful, and it provides a safe space to say, I've been there, done that, and provide that motivation for that individual who can do it too. And one point that is not included in ESPERT is really the idea of follow-up, not just a referral, but many EDs also have something in place where after that individual leaves, to follow up with them to see if that medication has been filled after their ED visit, or having connections within the ED setting, social workers, and again, peer recovery coaches and community advocates to maintain connection with those individuals to resources and to their visits that they're recommended for. And so while in an emergency situation, all providers are happy to help, but what you're really hoping is that that encounter begins the start of a new journey for them with the right support, and hopefully not to see them in an emergency situation again. And as Dr. Fingerhood mentioned, really commendable, the MAT Act, but I still think there are a few policy changes that we should be thinking of to even extend this coverage of opioid use disorder access a little bit more. And I say that because it is a national crisis, and so we should have a national approach. And what we find very frequently is that most of our legislation include clauses that has state variations. And if I had one wish to change, it would be to change that so that when we provide care, it is effective, it is comprehensive, and it shouldn't differ depending on the state that you live in. And I acknowledge that with all the recent changes, that is still something we can hope for because the crisis still continues and there's still so much more to do.
Thank you, Dr. Rodney, for those comments. And I know that among other areas that you also work extensively understanding and addressing trauma. So maybe during the question and answer period, you could speak a little to how we can better equip healthcare providers to identify and trauma and to practice trauma-informed care, which is critically important for so many with addiction. I just want to remind people we are accepting questions, and we'll move shortly to a question and answer period. You can email questions that you may have for any of the speakers to jhulive@jhu.edu. Next, let's turn to Dr. Saloner. Dr. Saloner, what type of care do individuals experiencing opioid use disorder receive, and where is there room for improvement?
Great question, and thanks for having me. So I think this is a perfect segue from the previous presentations, and I want to start by saying that one of the main goals of opioid use disorder treatment policy has been to move it into the mainstream of medical care. And this consensus that it should be managed like any other chronic disease and that it should be in the purview of primary care was one of the things that moved Congress, I think, to pass the 2022 repeal of the X waiver in the Omnibus Act. So I think this is a really hopeful moment. Many of the people who are listening to the webinar today probably know that access to care for opioid use disorder is a major challenge. Only about 1 in 3 people with opioid addiction actually receive any treatment. There's less awareness, however, about the quality of care that patients experience. And that's what I want to talk about. So let me just illustrate this with a few statistics. So we know that the gold standard for opioid use disorder care is treatment with any of the 3 FDA-approved medications, methadone, buprenorphine, and naltrexone. And while medication treatment may not be right for every patient, the opportunity to use medication should be universal. So I'm just going to set this up by talking about some of the places where we're falling off. And you'll hear me use the word half a few times. So more than half of all specialty addiction treatment programs still do not offer any medications for opioid use disorder. These are specialty addiction treatment programs. Roughly half of all patients in treatment are getting treatment without medication. And this is a problem because we know that the medications cut overdose risk by half. Another quality problem is retention in care. Yet we know that about half of all patients do not make it past 180 days in treatment. And so for many patients, this duration of treatment is just too short to provide any meaningful long-term clinical benefit. Then on the other side of the ledger, we have a problem that many treatment programs out there are either ineffective and some of them are downright predatory. I was part of a study that used a mystery shopper method where we had a research assistant pose as a person using heroin who wanted to get into treatment. And this person was often sold on very dubious treatments and told that basically she should expend every dollar that she had in her pocket and her family to go to care that may not have served any real kind of long-term treatment goal for the patient. So this is a huge problem that we have, just a kind of a Wild West marketplace with very few guardrails on the quality of care. So I want to briefly focus on 3 areas that should be the targets of policy to improve quality of care. The first one is to invest in care coordination initiatives. And I think this very much builds on what Dr. Fingerhood and Dr. Rodney were talking about. So I think the key is to create glue between pieces of the system that have historically been siloed. So you heard about the problem of linking the hospital with continuing care in the community, or a jail or prison, again, with care after release. But more generally, we need to be able to link specialty care to primary care. And there's models of how to do this. So in the state of Vermont, there was a major investment several years back to create what's known as the hub and spoke, so that there's central places known as the hubs where patients can start their care and then they can be referred out to primary care once they're stabilized. That's a statewide initiative. Maybe not every state can do that, but there's actually models of how to do something very similar at the level of a health system or even at the level of an individual care practice. So creating a kind of a network where there's concentrated care taking place in these hubs, but then opportunities to continue in care in your primary care setting. The second key is to measure what matters to patients. So we really need to focus on getting good metrics of quality of care, because that's how we can make improvements. To their credit, the NCQA, the National Care Quality Organization, has promulgated measures related to retention, engagement, and other metrics related to opioid use disorder, including the benchmark of 180 days. And that should be one of the key metrics that we focus on, because that really tells us, are patients meeting some standard of minimal adequacy? But beyond these claims-based measures, it's important to measure the experiences of patients themselves. So what we really need to do is get better metrics that reflect what we would call patient-reported outcomes. So how patients are experiencing their own recovery, what it means for them to be making progress. For some patients, that's abstinence. As my colleague, Dr. Sherman, will talk about, for other patients, it may be meeting other goals related to harm reduction and being safer in their drug use if that continues. Making progress in terms of being more engaged with family as a parent, having housing, having employment, staying out of the criminal legal system, and just having a better quality of life. These are the kinds of things that we should really uphold as the metrics of where we want to go. The third and final thing is to create financial incentives for meeting these targets. So the reality is that value-based care has been very slow to arrive to addiction treatment. And particularly for medications for opioid use disorder, we know that a very small number of clinicians treat most patients. So these are a great target for financial incentives to make sure that they are meeting these quality metrics. Federal payers can lead the way, including Medicaid, Medicare, and the Veterans Health Administration. So in conclusion, you can't fix what you don't measure. If you value it, you need to pay for it. And if you want opioid use disorder treatment to be in the mainstream of medical practice, you need to create expectations for payers and providers to take ownership for the sustained care of every patient so that they can achieve recovery. Thank you.
Thank you, Dr. Saloner, for those incisive comments. Finally, we'll turn to Dr. Sherman. Dr. Sherman, could you please talk about harm reduction and how it can be an effective tool for combating the opioid epidemic? Dr. Sherman, I think you may have been muted. If you can just check your check. We don't want to miss a word that you
Hello.
have. Now we can hear you.
All right, good. Thank you.
It's all yours.
Thank you for that, Dr. Alexander. And I really appreciate being a part of this panel with my esteemed colleagues today. I'm going to talk briefly about harm reduction as a philosophy, a bit of level setting, and also as a set of practical intervention strategies. I then will talk about some evidence around syringe service programs and naloxone distribution and end with some recommendations. Harm reduction is a philosophy that shapes responses to the adverse health and social consequences of harm reduction, of harmful drug use. There are a number of principles central to its practice, and I'm going to just talk about a few. First, harm reduction accepts that licit and illicit drug use exists, and it is important to minimize its harmful effects on individuals and the communities in which they live. Second is the belief that even when people are using drugs, they deserve access to services. Third, harm reduction programs meet people where they are, as Dr. Saloner said, referring both to where people are in the continuum of drug use and to where they are physically located in the community. Lastly, harm reduction calls for the non-judgmental, non-coercive provision of services, and that includes having the voices present of people with lived experience being key to the success of those services. In total, these principles really increase the reach of necessary services to some of the most at-risk opioid users without stigma. So now I want to talk a little bit about two practical strategies aimed to reduce the negative outcomes associated with drug use. There are a number of evidence-based strategies: syringe service programs, overdose education and naloxone distribution programs, drug checking, and overdose prevention sites have already been mentioned. Syringe service programs, or SSPs, are supported by an extremely strong and enduring global and domestic evidence base. They were started years ago, particularly to fight against a raging HIV epidemic among people that inject drugs. 30 years of research has provided compelling data as to their robust impact, expanding their impact beyond this initial primary purpose. So they also have been found through numerous studies to be effective in terms of reducing the odds of HIV, like I said, hepatitis B, hepatitis C, having problematic wounds and soft skin tissue infections. They're cost effective, are associated with safe disposal of used syringes, studies have found, and are an important distribution point for naloxone, and also have been found to be associated with the uptake of medicated assisted treatment, or MAT. There is no evidence that they're associated with increased crime in neighborhoods where they're located. And although some of those studies were done in Baltimore 30 years ago, that's something that continues to be brought up, particularly as syringe service programs have grown tremendously in the US since 2015 in the current opioid epidemic. They serve as an entry point to a number of social medical services. And while their goal is not cessation of drug use, evidence suggests that SSP participants are more likely to enter MAT compared to non-participants. During COVID, SSPs demonstrated their ability to be nimble, responsive, and fill service voids. In a recent national survey, over 60% of programs reported increases in syringe and naloxone distribution, as well as on-site MAT distribution compared to the year prior. Telehealth was also added to a lot of programs and remain as a service offering. Moving on quickly to overdose education and naloxone distribution programs, they've been implemented in a number of settings, reaching people who use opioids, whether by injection or other routes of drug administration like smoking. Studies have consistently demonstrated that naloxone saves lives when it is sufficiently present in the event of an overdose. It's essential that naloxone become even more widely available to those likely to be in contact with people who use opioids, such as friends, their friends, family members, business owners in high drug areas, and first responders. So moving to a few further recommendations. First, and this has been talked about in terms of service integration, it's essential to integrate harm reduction services into existing health and human services. Integration into primary care centers, drop-in centers is both cost-effective and increases healthcare accessibility and also destigmatizes harm reduction services. Harm reduction programs, though, still continue to have great implementation barriers. While SSPs are legal in most states, they're still illegal in 11 states, and of the 220 counties that are considered most vulnerable for HIV outbreaks, only 47 have an SSP. I'm encouraged by the growing inclusion of harm reduction services in harm reduction in federal RFPs and policy efforts, including national drug control policies, the National Drug Control Strategies call to scale up harm reduction strategies such as naloxone drug checking and SSPs, or SAMHSA's harm reduction grants to support community-based organizations. Continued actions such as these will help scale up necessary services and save lives. I want to leave with one recommendation around federal funding of all supplies provided by syringe services, including syringes. This really would be an important next step to sufficiently support the growing evidence of harm reduction programs that are funded by and supported by the federal government. Thank you so much, and I look forward to any questions.
Outstanding. Well, thank you, Dr. Sherman, and thank you to all of you for your comments. We have received a number of questions, and so there's so many questions, so little time. So let me begin. I want to cover at a minimum briefly the fact that the overdose epidemic is not just opioids. That's the first. The second that we'll come to, I want to discuss briefly complementary and alternative treatments, that is treatments that aren't necessarily prescription drugs. And then the third is the pandemic and sort of the way the pandemic has shaped things. So let's just start with non-opioid drugs. I mean, the overdose epidemic it involves many different products. As you know, poly drug use is often the norm rather than the exception. And we've seen increasing harms from methamphetamine and designer drugs. We received a question that noted, quote unquote, as we're making strides in combating opioid use disorder, we're facing emerging difficulties with designer benzos coming in from overseas and being used in the tribal community. Formulations seem to change rather quickly to skirt detection through standard drug screening and testing. So the question for any of you that wish to opine briefly is, how should these realities be used to inform policy and clinical care as we try to simultaneously address opioids and the fact that this isn't just a one drug epidemic?
I think drug checking and decriminalizing drug checking out of paraphernalia laws, which drug checking devices are still criminalized in a number of states, is a way to, there are machines that can test various substances within a substance, within a sample, and could sometimes get ahead of, even if there aren't treatments for certain substances, but actually could at least provide messaging. This is what's in drugs in your area, provide data dashboards. The state of Maryland is implementing, there's a pilot now, but ramping up a statewide drug checking program with various harm reduction organizations. But that's one way to keep a pulse on the finger of this constantly evolving market.
Yeah, I was going to add to what you said, Susan, in that frequently individuals are indeed buying what they think are something else, and it's also tainted with fentanyl, and that's the importance of the fentanyl testing strips, that we realize, I thought I was just using cocaine, I thought I was just using alprazolam. Unfortunately, there are people who sell pills that look just like the real pill, and they're not. We do see a lot of what we call toxidromes on the console service, where whoever asked the question is correct. We don't necessarily even know what the person took because the typical tests we do don't detect. There's lots of benzodiazepine-like products that aren't detected on the typical drug screens that we use. So yeah, so unfortunately, it's a really sad market as people are targeted. Methamphetamine in combination with fentanyl is very common now as well. Having said that, even though a lot of overdoses are polydrug, it's really the one it's when the fentanyl gets in there that we worry about someone stopping breathing and dying.
Brendan, I know that you have thought a lot and done research examining the pandemic and the way that the pandemic has impacted people with opioid use disorder. What reflections do you have? We're looking at the declaration of the end of the public health emergency. Perhaps we're approaching a new normal, which is the post-pandemic era. What lessons have we learned from the pandemic as we care for those with chronic pain or opioid addiction, or how do you think the world will look differently for that population in a year or two or three, or how do you hope it will look differently because of what we've been through with the pandemic?
Thanks for the question. I'm going to talk about bad news and good news. So start with the bad news. So Dr. Sherman and I actually collaborated on a study on people who use drugs during the pandemic. And what we found, I think, very much corresponds to what we see in the national data, which is that many more people started engaging in solitary drug use and using drugs that they felt themselves to be much more unpredictable. So that volatility in the drug supply that Dr. Fingerhood talked about was really accelerated by the pandemic and made a difficult situation a lot worse. So I think we are dealing with the echo effects of this kind of big social instability that the pandemic brought, greater isolation, and the fact that solitary drug use and the drug supply changed. I think that's all really, really bad for our efforts to make progress. The good news is that the pandemic also created a little bit more creativity around drug treatment itself. And then I think, as Dr. Sherman also said, using the same tools of telehealth and harm reduction. So it doesn't fix everything, but I think the idea that many patients, we learned, could do just fine coming into their clinic less often and getting their medication in a way that was more convenient, more take-home days of methadone, better access to a telehealth provider. This is the future. So I am glad that the Biden-Harris administration is committed to trying to make these changes permanent. I do think the end of the public health emergency poses some additional risks. One of the risks is that Medicaid is going to undergo a huge change. We're going to see millions of people leave Medicaid rolls, and this has been a major source of funding for treatment. So finding ways to connect with those folks and get them access to care during this difficult period is something that we all need to remain very focused on.
Thanks. Anyone else on the pandemic and what we've learned or what you hope that we've learned?
I was going to say, I think we've learned that telemedicine can work. And there's a lot of literature looking at telemedicine and effectiveness for opioid use disorder. And also, I'm going to say this, that we were over depending on urine drug screens, and that we don't need frequent urine drug screens to judge whether or not someone's doing well.
Thank you. Well, I do want to come back to complementary and alternative medicine, so I'm not going to leave that one completely. But I'm also thinking about veterans. And Tamar, I know that this is a population that you have worked with some and are interested in. And of course, veterans have hardly been spared from the opioid epidemic. There are many, many veterans living with chronic pain. And many that have either active addiction or are living in recovery. And I just wondered if you had any reflections either on sort of the current state of affairs for veterans with respect to the opioid epidemic, or particular programs or services that you either think are working well or that you would like to see increasingly adopted so as to meet the needs of veterans with opioid use disorder or who are living in chronic pain and using opioids.
Thank you for that question, Caleb. And we do know that veterans are diagnosed at a much higher rate for opioid use disorders than non-veterans. And another disorder, mental health disorder, that is particularly problematic in this population is PTSD. And then it's no surprise that there's a huge overlap. And so the statistics vary from 2% to 60%. The point is that when we see such a comorbidity, we need to answer two questions. Which one came first, the PTSD or the OUD? And the next one is why? And so approaching this from a place that nobody is going to go out and willingly seek to have an opioid use disorder, nor do they willingly go out and seek PTSD. And I think from that standpoint, we start to change the language around stigma and seeking care, and recognizing that many times an individual is seeking opioid as a reflection of treating chronic pain and the limited alternatives that are available for treating chronic pain. And so whether they're in a veteran or non-veteran group, that is sometimes the biggest reason, is that there's very few options available. And maybe another mistake we keep saying is that veterans have access to the VA system, so they have easy access to healthcare. This is not always true. And the barriers for seeking mental health care often lead individuals to turn into opioids for rapid relief. And that is literally it. They want to numb the pain either from physical pain or from PTSD. And so one of the strategies that I think we need to examine is that this individual's choice to self-medicate for chronic pain or with opioids, what are they trying to avoid? Are they trying to avoid work, or is it really the symptoms? And then what do we do? And so one of the strategies is what is called a mutual maintenance model, where both are going to exist together, both influence each other. And so one is going to exacerbate the symptom of the other. So this idea of collaborative care is not utilized in this population enough, because again, this idea that they go to the specialist hospital to get care, which comes with its flaws, but really what we need is non-stigmatized care, seeking what the real underlying problem is for seeking pain medication or relief of symptoms, and then coordinating with their other providers to get to the real root of the problem and taking away the shame and the stigma to encourage them to seek care, because ultimately that's what it comes down to. Encourage them to seek the right medication, the right care from the right person.
Well, thank you for those comments. And I'm reminded of Dr. Saloner's comment as well, that we need to invest in care coordination, or as he put it, putting glue between pieces of the system that have historically been siloed. And it sounds like that may be no less important or as important in the veteran system as anywhere else. We did receive a question from one of our participants on peer navigators, and they wrote, quote unquote, "We keep mentioning peers as if they're abundant and if they're uniform standards for peers around the country. Neither is true. Should there be minimum requirements for peers in terms of their training? What subject matter should they be trained in?" I wondered, Dr. Sherman or Dr. Fingerhood, if you wish to opine on that one.
You can go first.
Yeah, so that's a great question. So there is a lot of training that I think isn't always identical. So I think that it would be helpful to have some standard of training. here within Johns Hopkins, there's a training program for peers, and there's a lot of through the health department, there are trainings for peers, and they really do somewhat overlap. But I think we probably do need some uniformity. Certainly, a lot of the training is related to confidentiality and knowing limits and boundaries as well. But I think that's a great question, because I think there should be some way to standardize them.
I like that you focused on confidentiality being something important to train on. I think what often happens when institutions professionalize things like peers, there is a risk of people being laden with a lot of requirements of sobriety, which haven't always worked, and which is not what you're saying, Michael, but just to say, I think it's important to be really upfront about what it's meant to be a peer, what people really need. Sometimes people are trained out of being truly a peer. So harm reduction, there are a lot of different peer models, and there's a great organization in Baltimore, Be More Power, where people who are near peers who sometimes having that kind of regular pay, respect, and role, which we know is so important to all of us, really helps with people engaging in medication-assisted treatment and stopping using street drugs, et cetera. So
I was going to make one other point, which we had to battle here at Hopkins, was the fact that unfortunately many peers have a felony in their record, and we had to change the rules that you can hire someone who's had a felony in the past because they're in recovery now, and that we want people, peers who have lived background, to be able to be hired. So that's something to think about.
Thank you for those comments. We had a question about the primary care workforce. Dr. Saloner, I have a feeling I know what your answer is going to be, but the question is, or the comment is, recommendations that we provide more treatment in primary care settings is fine in theory, but in practice we lack the workforce to do this. Not nearly enough SUD, substance use disorder treatment professionals exist to meet demand, and a large reason is that the profession pays so poorly. How can we remedy this problem?
Yeah, thanks. There's a few layers to that question. So with regard to the workforce, it's a very region-specific problem. I mean, there are parts of the country where there's not enough primary care, full stop. So when there's not enough family medicine or pediatrics, and we know there's like a crisis right now in people who care for adolescents, we don't have enough of that workforce, or geriatricians. So I certainly would not be one to say that there's not, that the workforce is totally great right now. But I think we can do more with the workforce we have. And one point that I would really make about treating addiction is that if you actually look into the numbers, most patients are being treated by about 5% of the total available workforce. There's a very concentrated phenomenon. People like Dr. Fingerhood are really like leading the way because they have these high volume, high quality practices. So, short of cloning Dr. Fingerhood, we have to figure out ways to bring treatment to scale using the resources that we have. And some of it may be adding more support to clinics that have already demonstrated that they can do high quality care, adding more nursing staff, adding more paraprofessionals, peers, as was mentioned. I think these are all part of the sort of the secret sauce of how to make this work. So I don't want us to feel paralyzed by this question of workforce, because I think that there's a lot more that we can do with what we have.
Thank you for those comments, Dr. Saloner. I want to come back. I have a final question for all of you, but I want to ask one first, which is about this, the non-pharmacologic therapies. And here I'm talking about their use and appropriateness for chronic pain, not for treatment of opioid use disorder, but for the management of chronic pain. And, Dr. Let's see, I guess we heard about some of the challenges that patients face in accessing different types of treatments. And I guess I wondered if one or more of you might speak briefly to both the evidence base to support treatments such as physical therapy or biofeedback or meditation or yoga and the like, the evidence base that exists for them, as well as what needs to be done policy or clinically wise in order to make these more available to patients that are living in pain.
So Caleb, the way I think about this in using other non-drug therapy is from a philosophical point of view is we do want individuals to be set up for success with less dependence on drugs. And that because that's where the problem started. The quick fix, the rapid fix, and we really are promoting a change in lifestyle. So we know specifically for pain that something is physically wrong. They didn't make it up. There is damage that they can correct in gentle ways like physical therapy. Biofeedback specifically has shown good evidence for incontinence, and really that's related to muscle. So if you think of it as a granular level, again, it's a physical understanding of the body, where and when it's happening, and to provide that individual to understand what is happening in their body. But including therapeutic approaches. So motivational interviewing is one that is particularly good around changing behavior, but because there's pain underlying, is then you get to make better choices. So while we focus on the body as well, thinking about the emotional responses to how they experience pain and the options that they choose in those instances is, so it's not a singular modal approach, it's a multimodal approach, but the first part is changing their thinking and letting them know that they do have options available outside of drugs.
Thank you. Dr. Fingerhood, any thoughts or reflections about the role of these treatments?
Yeah, I certainly in the past year, we have a journal club where we review papers, and we reviewed a paper that looked at requiring non-pharmacologic measures in order to continue to receive opioids for chronic pain. And the study showed effectiveness. So I think we have to think about these other things. They work, and it should be part of an entire way of trying to improve people's lives. So we have to get away from pain scales and get to the point where how are we going to improve our patients' function and what they do each day. The pain scales and asking people a pain number is how we got into this mess.
Yeah, I mean, I can remember during training sort of having some notion that we should bring people to zero. And I think that's often not practicable, and has been cited as one of many clinical lessons or pearls that in fact has maybe done more harm than good. Well, we just have a few minutes left, and so I wanted to ask finally, maybe this is a little bit crystal ball also, but the opioid epidemic, we're here more than 20 years later after the alarms were first sounded. And as I know all of you know, our panelists, and I know those of you joining us know from those that you work with or serve, or perhaps friends or family, there's no shortage of enduring loss. And this is despite the fact that there's so much evidence and so many efforts and so many tools that we have that we can bring to bear to prevent further harm. So my question for you, the panelists, is as we look forward, what gives you the most hope? And so I just welcome each of you to opine, and then we'll wrap things up.
I could start. I feel hopeful because we're having better conversations, including this one. I'm glad that we're no longer talking as much about medications substituting one addiction for another. Of course, there's people who believe that, but I meet sheriffs who are excited to treat addiction in jail. I meet EMTs who want to help people who they've revived in the field. There's all kinds of people who see this as their problem. And when we start seeing it as a problem for all of us, then it's a solution that we can all come together and work towards. So I'm really excited about that.
Thank you.
So I'll add to that comment. Same thing. So when I have a church reach out to me, can you do an naloxone training? If one member of our church is a family member who needs help, what do we do? Medical students reaching out, can I do an elective with you? So I'm interested in addiction medicine. What do I need to know? I teach a medical student course. In the School of Nursing and the School of Public Health, there's so many people who want to impact, and that gives hope.
Thank you.
Conversation, having big conversations and more people talking to one another is what I was going to say. I think out of despair comes hope. I mean, we just lived through this surreal time And, you know, it's still outrageous. We don't think about the same. I hope that the hope is that having seen what implementing prevention for COVID did in a relatively short period of time, can also that urgency is taken for the opioid epidemic, and also faith that we can have these conversations, it can impact policy and shift the needle. Because the fact that 108,000 plus people are dying, I just read something that I wrote like 5 years ago. It was like 50,000 people. I mean, the numbers are astounding. I hope we're never comfortable with the numbers. And I hope that what we just went through with COVID can help us respond to the opioid epidemic.
Thank you.
I think I'm hopeful for two things. One, that the national conversation has changed. And although not perfect, that Mainstream Addiction Treatment Act does signify that they're willing to make progressive changes, and we'll just push them to start taking away some of those barriers. But anecdotally, I'll just share that one of my patients recently gave me 2 doses of naloxone, and that's because I ran out, because I had used some to revive another patient. But in that moment, what that told me is that she had gone to an education service to get them. And she also shared with me that when I have extras, I give them to my family, which means that even at the level of the community, that conversation is taking hold and individuals are taking it seriously. And I'll just mention that this patient was someone who is in a recovery program. So maybe not necessarily for her, but she definitely feels responsible for her peers who she lived with, and was able to give that to me as a provider, that I could have them on access. So that definitely gives me hope to keep doing the good fight and the good work.
Well, thank you so much. And I'll say that all of you give me hope, including all of you who have joined us today for this important conversation. I would like to thank our panelists again, Dr. Fingerhood, Dr. Tamar Rodney, Dr. Brendan Saloner, and Dr. Susan Sherman for joining me today. And I'd also like to, again, give a big thank you to all of you who attended this briefing, and to those of you who submitted questions for our experts. As we've heard today, unfortunately, morbidity and mortality from opioid addiction and overdose remain at catastrophically high levels in many communities around the country, and the urgency is palpable. There really is not a moment to lose. So I thank you for your interest in and your commitment to these matters. I'd also like to thank Kristen Reek, Kelly Allen, and Sahand Yazdanyar for their leadership in orchestrating today's event. A recording of this event will be made available on this website, which is the online home of the Johns Hopkins Congressional Briefing Series. Thank you.